Howdy, how y'all doing? I'm Dr. Jose Favora, and today we're going to be going through an overview of adrenergic agonists. So before I get started, let's talk about the objectives of today's lecture. All right, number one, I want to make sure that by the end of this you understand the physiology of the adrenergic neuron. I know you've gone through this before, but in order to really understand the pharmacology of what we're talking about, you've really got to get down to the meat of what the adrenergic neuron is all about. The second objective is really to confuse you through the use of a lot of crazy terminology about alpha receptors and beta receptors, and we might even throw a couple of dopamine receptors in there. Now, number three, I want to make sure that we're going to take our knowledge of these adrenergic receptors and we're going to apply them in terms of understanding the different drugs that are available for use clinically. The fourth and most important objective is I want to make sure that by the end of this you're able to apply the drugs discussed in a clinical setting. I want you to make sure that you understand their clinical utility. Let's start with something basic that I'm sure you guys already completely understand. Let's go back to the word adrenergic. Adrenergic. If you look it up in Stedman's dictionary, it says relating to nerve cells or fibers of the autonomic nervous system that employ norepinephrine or epinephrine as their neurotransmitter. The term adrenergic also relates to drugs that mimic the action of the sympathetic nervous system or the action of norepinephrine and epinephrine or the components thereof. So I want to make sure that first of all we start off talking about the nerves, talking about the autonomic nervous system, and then we're going to shift gears and start talking about the drugs that mimic the action of the sympathetic nervous system. So the sympathetic nervous system is pretty easy to understand. Right now, I'm going to tell you that I'm having a serious sympathetic response. The fight or flight system. We're talking about things like tachycardia. My heart is racing right now. We're talking about vasodilation to improve blood flow in the muscles. You're going to notice that as you get nervous, and as I get nervous throughout this lecture, I'm going to shift my legs and I'm going to shift my arms because the blood flow is great right now to those muscles, and I'm ready to run. If we get the camera and zoom in on me, you're going to see pupillary dilation, mydriasis. You're going to notice that I'm sweating. And you're going to notice that in my splanchnic beds, you're not going to notice it, but I'm going to notice it, that there's going to be actually some vasoconstriction going on because we got to get the blood to where it needs to get to. Finally, you're going to notice that I'm breathing a little bit heavy and I've got some bronchodilation happening. So these are all the things that we need to think about when we think about fight or flight, when we think about sympathetic nervous system, and when we think about the adrenergic drugs or the adrenergic agonists that we're going to be using. Let's start off by talking about neurotransmission at the adrenergic neuron. Okay? This is kind of a 6-step process, and I want to make sure that you understand this, so we're going to go through it step by step. The first process in neurotransmission at the adrenergic neuron is synthesis of norepinephrine. So, tyrosine is transported into the axoplasm by a sodium-linked carrier, where tyrosine is basically hydroxylated by tyrosine hydroxylase, and it becomes dihydroxyphenylalanine, which is DOPA. Now, DOPA, dihydroxyphenylalanine, say that a million times, is decarboxylated by, you guessed it, DOPA decarboxylase to form dopamine in the cytoplasm of the neuron. Now, an important clinical side note, that monoamine oxidase works at this site to catalyze DOPA, dopamine, and norepinephrine into inactive metabolites, which are then excreted in the urine. So, somewhere along the way you've heard of MAO inhibitors, and these drugs will basically increase dopamine and norepinephrine. So, something to think about. All right, that's enough of a clinical side note for the moment. Going back, now, once we've created dopamine, we come to the next step in neurotransmission, which is storage. Dopamine is taken and then stored in synaptic vesicles. Now, in the synaptic vesicles, it's hydroxylated by dopamine beta hydroxylase to form norepinephrine. All right? Now, so basically now we've got vesicles in the adrenergic neuron that contain norepinephrine. All right? Now, these vesicles also contain a bunch of other co-transmitters besides norepinephrine and dopamine, but that's beyond the scope of this lecture today. In the adrenal medulla, and now we're going to switch gears for just a second and go over to the adrenal medulla, norepinephrine is methylated to form epinephrine. So on stimulation, the adrenal medulla actually releases about 80% epinephrine and 20% norepinephrine directly into the circulation. Now, this is important as well for the adrenergic response. So once we've got norepinephrine in the synaptic vesicles, it's time to release the norepinephrine. Now, an action potential arriving at the nerve junction basically triggers an influx of calcium ion into the cytoplasm of the neuron. And this influx causes those vesicles to basically fuse with the cell membrane and release those neurotransmitters into the synaptic space. Now, norepinephrine basically binds to either the postsynaptic receptor on the effector organ, or it binds to the presynaptic receptor. And this leads to a triggering of an intracellular cascade and basically the action effect, which we're going to go over later on in this lecture. Now, what happens to the norepinephrine once it binds? Well, norepinephrine, once it binds, it basically has three fates. It can either, number one, diffuse out of the synaptic space and into the circulation, or number two, and this is probably the important one I want you to remember, it can be metabolized by the postsynaptic cell membrane associated catechol O-methyltransferase. Catechol O-methyltransferase is COMT, and I'm saying it over and over again because it's going to come up again in the lecture, and I want you to remember it. COMT. Now, the third fate of norepinephrine is that a sodium-potassium ATPase pump can pump that norepinephrine back into the neuron. Now, it's interesting because this pump is inhibited by tricyclic antidepressants and by cocaine. Let's go back to adrenergic receptors now. These receptors are found on the postsynaptic space as well as on the presynaptic space. Adrenal receptors are G-protein coupled receptors. Activation of a receptor leads to activation of a G-coupling protein. Now, the activated subunit, and I'm getting into some biochemistry here now, all right? But the activated subunit basically activates phospholipase C, which leads to the release of inositol 1,4,5-triphosphate, or IP3. Well, needless to say, it's a complex process, and I don't want to go completely into details about it here. I don't think we need to completely rehash it. But the important point is that these receptors are classified based on their response to epinephrine, norepinephrine, and isoproterenol. There are basically three families of receptors that I'm going to go over today, and that are important in terms of the pharmacology that we're going to be talking about later. There's the alpha receptors, which are classified into alpha 1 and alpha 2. The beta receptors, beta 1 and beta 2. And then there are the dopamine receptors, which are dopamine 1, 2, 3, 4, and 5 receptors. I want to make sure that we're going to touch on dopamine receptors, but we're going to spend the bulk of our time today on the alpha receptors and on the beta receptors. So let's start with alpha 1 receptors. Alpha 1 receptors are present on the postsynaptic membrane of effector organs and basically are involved in constriction of smooth muscle. We're going to say that, I'm going to say that over and over and over today, alpha-1 receptors and vasoconstriction, as well as constriction of smooth muscles. So what happens is that when that norepinephrine binds to the alpha-1 receptor, it causes a release, again, of the inositol 1,4,5-triphosphate, which releases calcium ion from the endoplasmic reticulum and into the cytoplasm of the postsynaptic cell. And basically, this is going to lead to the cascade that leads to the effective cell response. Alpha-2 receptors are located primarily on the presynaptic nerve endings. All right? They're also found in a couple other places that are important. They're found in the beta cell of the pancreas, and they're found in certain vascular smooth muscle cells. So stimulation of the alpha-2 receptor causes, think about this for a minute, it's on the presynaptic nerve ending. It's going to cause what's a feedback inhibition of norepinephrine release from the adrenergic neuron. It's basically what's called an inhibitory autoreceptor. Basically, these are found on the presynaptic nerve endings, and they're going to shut down that response. Now, they're also found, just to confuse the issue a little bit, they're also found on presynaptic nerve endings in parasympathetic neurons. So stimulation also inhibits acetylcholine release. That's kind of beyond the scope of today's discussion, but it's important to mention here. Now, it's also important to mention that alpha-2 receptors are not G-protein mediated like the alpha-1 receptors we talked about earlier, but rather by inhibition of adenyl cyclase and decreased levels of cyclic AMP. Lots of biochemistry today. Beta receptors. Beta receptors, I want to step back for a second and remind you that all of these receptors are classified based on their response to epinephrine, norepinephrine, and isoproterenol. Now, beta receptors have a very strong response to isoproterenol. There are two types of beta receptors we're going to talk about. The beta 1 receptors, which are found primarily in the heart, and after their response to isoproterenol have an equal affinity for epinephrine and norepinephrine. There's also beta 2 receptors that are found in the vasculature of skeletal muscles, and their response to epinephrine is much greater than their response to norepinephrine. I want to step back and now give you a summary of the characteristic responses mediated by the receptors. If you slept through all of the beginning of this lecture and you plan on sleeping through all the rest of the end of this lecture, I want you to pay attention right here. So wake up. All right, good. You awake? All right, good. 4 types of receptors, and I want to clearly talk about the response each receptor is going to create. Alpha-1 receptors cause vasoconstriction. We mentioned this earlier. They're also going to cause increased peripheral resistance. Now, all of this is going to cause an increase in blood pressure. We also mentioned earlier that the idea of mydriasis or pupillary dilation, and alpha-1 receptors are integral to this process. And finally, they're integral to the process of increasing the closure of the internal sphincter of the bladder. I mean, fight or flight, you know, you're going to take off running and you don't have time to pee in your pants. All right. The alpha-2 receptor, again, being on the presynaptic membrane, is going to cause an inhibition of norepinephrine release. It's also going to cause an inhibition of acetylcholine release. And finally, and this is kind of on the side, we mentioned it, I kind of glossed over it, but I want you to remember it, alpha-2 receptors are going to cause an inhibition of insulin release. Now, going on to the beta receptors. Beta 1 receptors, being found primarily on the heart, are going to be integral in causing tachycardia. They're also going to, when stimulated, increase myocardial contractility. Now, they're found on other places besides the heart. Beta 1 receptor stimulation leads to increased lipolysis. It's good for guys like me. Beta 1 stimulation also increases the release of renin in the kidneys. And that's going to become important later as well when we start talking about the drugs. Now, the fourth receptor, you can fall asleep right after I finish talking about this again, but the fourth receptor we're going to talk about is the beta 2 receptor, and the beta 2 receptor being found in the skeletal muscles is going to cause vasodilation, and that's going to cause a slightly decreased peripheral resistance. It's also going to cause increased blood flow to these areas, which is going to be related to an increase in muscle and liver glycogenolysis. I want you to remember when we talk about all of these things that we're talking about the fight or flight response. And why would we want to increase muscle and liver glycogenolysis? Well, kind of makes sense. You need more sugar so you can start running, so your muscles can start going, right? You also need more oxygen. And so beta 2 receptors are involved in bronchodilation. They're also involved in the increased release of glucagon. Now, as long as you remember these responses that are mediated by these receptors, it becomes very easy, very easy, right, like everything else in medicine. It becomes very easy to figure out which drug you need, when you need it, what the drug's response is, when you're going to use it, how you're going to use it, and where it becomes clinically useful. Now that we've talked about the receptors here for a bit, and now that everything is crystal clear, let's talk a little bit about the adrenergic agonists themselves. Most adrenergic agonists are derivatives of something called beta-phenylethylamine. Adrenergic agonists all differ in terms of some basic substitutions. Substitutions on the benzene ring or on the ethylamine side chains of these molecules produces a variety of compounds with a varying ability to differentiate between alpha and beta receptors. Also gives them a varying ability to penetrate the CNS, which again is always important when we start talking about drugs. There are basically two types of adrenergic agonists, and I want to mention these specifically so that you've heard other terminology. Now, the first term that we use for these is catecholamines. And catecholamines, the catecholamines in this group are epinephrine, norepinephrine, isoproterenol, and dopamine. And these drugs, the epinephrine, norepinephrine, and dopamine, are actually found physiologically in the body. Isoproterenol, which I've mentioned a couple of times before in today's discussion, isoproterenol is actually a synthetic compound that mimics the rest of these drugs. So catecholamines as a group have a high potency, have high potency in activating alpha and beta receptors. They are also rapidly inactivated by COMT. I told you it would come up again. Rapidly inactivated by COMT in the synaptic space and by MAO intraneuronally. So COMT is also found in the gut wall. That becomes important. MAO is found in the gut wall, and it's also found in the liver. So you'll never guess what's coming next. Well, a lot of these drugs don't go well orally. You give them orally, they get inactivated very quickly by these enzymes and are clinically useless in that setting. Now, catecholamines are also characterized by this idea that they have very poor penetration into the CNS. Now, non-catecholamines. We had catecholamines, so we got to have non-catecholamines. These are compounds that are lacking the catechol hydroxyl groups that catecholamines have. So these drugs have a longer half-life, and because they lack these groups, they aren't really inactivated by COMT. There are 3 drugs that I want you to remember in terms of non-catecholamines: phenylephrine, ephedrine, and amphetamine. And we're going to talk about all of these later. These are also poor substrates for MAO, and they have a highly increased lipid solubility, which permits them greater CNS penetration than the catecholamines.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together, we'll go through the quick review in the study guide.
Hello and welcome to Who Wants to Be a Gunner, the show where we ask the tough questions that separate the real doctors from the future veterinarians. Let's meet our next contestant, Michael Rosenthal. Hello, Michael. Welcome to the show. Tell me a little bit about yourself.
Well, I'm a third-year med student, I'm post-call, and I haven't slept in 32 hours.
32 hours? You seem pretty chipper.
Oh yeah, I'm totally buzzed on Starbucks and Skittles right now.
I see. This ought to be entertaining. All right, let's play Who Wants to Be a Gunner? Okay, Michael, for $100, what is the primary neurotransmitter released by adrenergic neurons? A, norepinephrine. B, acetylcholine. C, nicotine. Or D, ephedrine.
Norepinephrine?
Is that your final answer? I'd hate to see you blow it on national television in front of your entire family with all your attendings watching.
Norepinephrine, final answer.
The primary neurotransmitter in adrenergic neurons is A, norepinephrine. Thanks to dumb luck, Michael has managed to win himself $100. Will he walk away with his cash and his pride? We'll find out after these messages.
Hi, I'm Dr. Chris Lewis. It's time for your quick review number 1. Let's get started. Describe the 5 steps of neurotransmission in adrenergic neurons. So we had a nice graphic of this during the lecture. I wanted you to have this in outline form, just another way of studying this. So let's first talk about the synthesis of norepinephrine. Tyrosine is hydroxylated to DOPA, and then DOPA is decarboxylated to form dopamine. For the storage of norepinephrine in vesicles, dopamine is hydroxylated to form norepinephrine, and then in the adrenal medulla, norepinephrine is methylated to form epinephrine. And then we get release of norepinephrine. You get influx of calcium that causes vesicles inside the neuron to fuse with the cell membrane and expel their contents into the synapse. And then for the binding of the receptors, norepinephrine can bind to either postsynaptic or presynaptic receptors. And then finally, for removal of norepinephrine from that synapse, you can get diffusion out of the synaptic space and into the circulation. Or it can be metabolized by COMT, which we talked about in this lecture as well. And then also there's a sodium-potassium ATPase pump that can pump norepinephrine back into the neuron itself. All right, so now you've got another way of studying that whole series of events. Next, match the following receptors with their location. So where are we going to find alpha-1 receptors? Where are you going to find them on the postsynaptic membrane of the effector organs? Alpha-2, where are we going to find our alpha-2s? Where are you going to find it on the presynaptic nerve endings? So remember that a lot of these are postsynaptic, but the alpha-2s are actually presynaptic nerve endings, vascular smooth muscle, and beta cell of the pancreas. All right, where are we going to find our beta-1s? Beta-1s, a whole bunch of beta-1 is in the heart, but you'll also find it in the kidneys as well. And then for beta-2, you're going to see this in the lungs, you're going to see it in the GI tract, vascular smooth muscle, and the skeletal muscle and liver. Next question. What are the characteristic responses by the following adrenal receptors? So you just have to memorize this stuff. We've gone over this a couple of different times. We'll go over it again even. If you can really memorize these alpha 1, alpha 2, beta 1, beta 2 reactions, then you're going to be that much better off when you talk about the drugs that either are agonists or antagonists for these drugs, for these receptors. So alpha 1. Remember, alpha 1 has a lot to do with peripheral resistance. So you're going to get vasoconstriction, increased peripheral resistance, increased blood pressure, mydriasis, and urinary retention. Alpha 2. Alpha 2 is a little bit different than our other adrenergic receptors because it's on presynaptic neurons, and you see inhibition of norepinephrine. So it's our negative feedback. It's going to stop that further release of norepinephrine. Also inhibits acetylcholine release and inhibition of insulin. Beta 1, where do we find our beta 1s? On the heart. So when you agonize a beta 1, you're going to get tachycardia, increased myocardial contractility, increased lipolysis, increased release of renin. And then beta 2, you're going to get some vasodilation, slightly decreased peripheral resistance, increased blood flow, increased muscle and liver glycogenolysis, and bronchodilation. You're also going to get some increased release of glucagon. Next question. How are catecholamines metabolized? Well, we talked about this early in the lecture, but COMT are in that synaptic area, so postsynaptically, that norepinephrine can be broken down. And then think of MAO. So MAO will break down your catecholamines intraneuronally. So inside the neuron, that MAO is working, and that's why when we have MAO inhibitors, you're going to have an increased concentration of those catecholamines. Moving on. Why do the non-catecholamines have greater penetration into the CNS? Well, this is true of any drug we talk about or any other thing. You have to have high lipid solubility in order to get into the CNS. So the non-catecholamines have a greater lipid solubility, therefore they're going to get into the CNS better. All right, so that's going to conclude our quick review number 1. Let's get back to the lecture.
So now that we've talked about catecholamines and non-catecholamines, I'm going to try and confuse you just a little bit more by telling you that I'm actually going to break down the rest of these drugs into 3 major groups. The direct-acting adrenergic agonists, the indirect-acting adrenergic agonists, and the third group, the mixed-action agonists. Let's talk first about direct-acting adrenergic agonists. These are characterized as drugs that basically bind directly to adrenergic receptors without interacting with the presynaptic neurons. These drugs include epinephrine, norepinephrine, isoproterenol, dopamine, dobutamine, oxymetazoline, phenylephrine, methoxamine, clonidine, metoprolol, albuterol, terbutaline, salmeterol, and formoterol. We're going to start with epinephrine, kind of the penultimate adrenergic agonists, all right? Epinephrine is a catecholamine that's synthesized again from tyrosine, and it's primarily synthesized in the adrenal medulla. It interacts with both alpha and beta receptors. Now, it's important to understand with epinephrine that at low doses, you get a lot more of the beta effects on the vascular system, like vasodilation. And at high doses, the alpha effects or vasoconstriction tend to predominate. When we talk about epinephrine, we've got to talk about its cardiovascular actions. With the beta 1 receptors, when epinephrine comes in contact, it produces an inotropic effect of increased contractility of the myocardium. It also produces a chronotropic effect of increased rate of contractions. The beta 2 receptors are going to dilate the blood vessels that are flowing to the liver and flowing to the skeletal muscles. Epinephrine also has some respiratory effects, primarily at the beta 2 site. Beta 2 receptors cause a powerful bronchodilation by acting directly on the bronchial smooth muscle. Now, not only that, but we're going to increase glycogenolysis and get more sugar out to where it needs to get to. Now, the alpha effects of epinephrine include constriction of arterioles in the skin, also constriction of arterioles in the mucous membranes and in the viscera. Now, one of the important distinctions we're going to make here between epinephrine and these other drugs is that epinephrine actually causes a decrease in renal blood flow. So the cumulative effect of epinephrine is increased systolic blood flow coupled with decreased diastolic pressure and decreased renal blood flow. Another very nice effect of epinephrine is that it inhibits the release of allergy mediators such as histamines from mast cells. These effects become particularly important when we start talking about the clinical uses of epinephrine. And I'm going to get to that in just one more second. I mentioned hyperglycemia. The beta-2 receptor stimulation is going to increase glycogenolysis in the liver. Beta-2 receptor stimulation is also going to increase release of glucagon. And the alpha-2 stimulation is going to decrease release of insulin. There's also a nice little endocrine effect that I mentioned earlier. Epinephrine is going to stimulate beta-3 receptors. I'm starting to confuse you. I just added a third one. But epinephrine stimulates beta-3 receptors in the adipose tissue to cause lipolysis. Again, a nice little effect for those of us that need it. So what do we use epinephrine for? Well, now that you understand the epinephrine and how it interacts with all of these receptors, it becomes really simple to know what we use it for. Obviously, we've talked about bronchodilation, and we've talked about a mast cell effect. So epinephrine is very clinically useful in acute asthma. In fact, it's the primary drug of emergency treatment of bronchoconstriction. It's a drug of choice in acute asthma as well as in anaphylactic shock when we administer it subcutaneously. Epinephrine is also used in open-angle glaucoma because it decreases intraocular pressure when administered topically. The third place where we're going to find epinephrine use is in cardiac arrest. And epinephrine becomes very useful for restoring cardiac rhythm in cardiac arrest regardless of the cause. And finally, the fourth use that's important clinically is it's useful in local anesthetics. We find it a lot in lidocaine solutions. What it does is it produces vasoconstriction, again, those alpha receptors, those pesky little alpha receptors at the injection site, causing the local anesthetic lidocaine to be able to persist at the anesthetic site. A little bit about the pharmacokinetics of epinephrine. Epinephrine has a very rapid onset, but it has a very brief duration of action. It's not administered orally. Again, we talked about MAO in the intestines, and we talked about COMT, the two metabolic pathways, earlier. And these enzymes are going to break down epinephrine in the gut. Completely useless when administered orally. Now, metabolites of epinephrine are excreted in the urine. Epinephrine, as you can imagine, has some adverse effects, and it becomes important to remember this, so dig out the PDR, take a quick look. Epinephrine causes CNS disturbances. Wait a second, didn't he say that epinephrine doesn't really cross the blood-brain barrier? Well, it does to a certain degree, all right? And it's going to cause some CNS disturbances, like anxiety, fear, tension, headaches, tremor. It's also going to cause some systemic adverse effects. It can cause hemorrhage, which can be a result of the increased blood pressure. It can cause cardiac arrhythmias. Remember, it causes tachycardia on those beta-1 receptors. and it can also cause pulmonary edema. Epinephrine also has some very important interactions that I think are important to bear mentioning at this point. Hyperthyroidism may enhance the cardiovascular effects of epinephrine. So if you've got a patient with hyperthyroidism, then you're going to need to decrease the dose of epinephrine. I mentioned cocaine, and cocaine is going to get a lot of mentioning on this, during this particular presentation. Cocaine prevents the reuptake of catecholamines, so epinephrine and cocaine really don't mix. You put them together, and it's really going to enhance those cardiovascular side effects. Finally, you're going to see an increased release of endogenous stores of glucose. So patients who have diabetes and who are given epinephrine are going to invariably develop hyperglycemia. Let's switch gears and talk about norepinephrine, which is kind of where we started earlier. Theoretically, norepinephrine, a direct-acting adrenergic agonist, should stimulate all the adrenergic receptors that we've talked about so far because it's involved in all of them. But in reality, the reality is, on the ground, in the hospital, clinically, you're going to see that at therapeutic doses, it's really the alpha receptors that are much more affected by norepinephrine than the beta receptors. So again, I want to break it down into the different effects that norepinephrine is going to have. We're going to talk first about the cardiovascular effects. And remember, when I said norepinephrine, I stuck it with the alpha receptors. So, digging back to those alpha-1 receptors, the first thing you're going to see is vasoconstriction. You're going to see increased peripheral vascular resistance due to the intense vasoconstriction of most of the vascular beds. So you're going to see an increase in the systolic and the diastolic pressure. And bradycardia, norepinephrine has much more vasoconstriction than epinephrine because epinephrine, again, has that beta-2 action causing vasodilation in the skeletal smooth muscles, while norepinephrine, not so much. Norepinephrine also has what we call a baroreceptor reflex. Now, in real life, on the ground, you're going to see that the increased blood pressure caused by norepinephrine induces a reflex rise in vagal activity by stimulating baroreceptors. Now, the reflex bradycardia is sufficient to counteract the local action of increased myocardial contractility. If we give atropine to block the vagal activity of norepinephrine, then norepinephrine produces a tachycardia, kind of as we expect. But in real life, norepinephrine doesn't produce the tachycardia that you would think would happen when we talk about the adrenergic stimulation and when we dig back to all the biochemistry we've gone over really quickly here just previously. Norepinephrine has some important therapeutic uses that I'd like to go through. In the clinical setting, norepinephrine is most often used for the treatment of shock. It raises the blood pressure, which is super important in shock, obviously. But norepinephrine is not preferred because it actually decreases renal blood flow, which we talked about earlier as well. It's also never used in the treatment of asthma because of the lack of beta effects that I've mentioned previously as well. Norepinephrine is such a potent vasoconstrictor that at the injection site, it can actually cause extravasation. So you got to be super careful with norepinephrine when you do use it in the shock situation. And you got to have these patients in the ICU monitored very closely. Not just for the extravasation, but because you don't want that blood pressure to go up too high and you don't want to box their kidneys with the decreased renal blood flow. A little bit about the pharmacokinetics. Again, you're going to find norepinephrine most often used in the ICUs. It's given IV for its rapid onset of action. The duration of action is only about 1 to 2 minutes after administration. It's destroyed by MAO in the gut if you try to give it orally, so you can't really do that. It's poorly absorbed if you try to give it sub-Q. And again, this is because of the vasoconstriction effect. The adverse effects of norepinephrine, they're pretty similar to epinephrine, but they bear mentioning again. The CNS disturbances of anxiety, fear, tension, headaches, tremor, hemorrhage resulting from increased blood pressure, cardiac arrhythmias, particularly in the setting of patients on digoxin, and pulmonary edema, which in the ICU setting is not quite so fun. So again, very similar to norepinephrine in terms of very similar to epinephrine in terms of the adverse effects. The next drug, the next direct-acting adrenergic agonist I want to go over is isoproterenol. And I know I mentioned this earlier, but it's a direct-acting synthetic catecholamine, which predominantly stimulates beta-1 and beta-2 receptors, really has a pretty insignificant alpha effect, even though the effect is there. Now, again, we're going to break it down in terms of the receptors, and I'm really trying to do this so that when you do this, when you're studying, you're going to look back and you're going to do the same thing. You're going to break each drug down in terms of its alpha and beta effects. Now, isoproterenol. Let's think again. The cardiovascular effects, it's going to stimulate the beta-1 receptors, and you're going to get an intense stimulation which is going to increase that heart rate, and it's going to increase the force of contraction, thereby increasing your cardiac output. In terms of endocrine responses to this drug, beta-1 receptors are going to increase lipolysis. Looking at the beta-2 receptors, again, we're going to dilate the arterioles of the skeletal muscle, so you're going to decrease peripheral vascular resistance. In terms of pulmonary actions, we're going to look again at those beta-2 receptors, and we're going to cause a rapid and profound bronchodilation. And beta-2 receptors are going to increase glucagon. Now, in terms of the endocrine effects of isoproterenol, neither of these is really clinically significant, but they bear mentioning. Isoproterenol has some important therapeutic uses. It's rarely used nowadays for acute asthma. Really rarely used because we've got better drugs out there now. It can be used in the emergent situation to stimulate the heart. In terms of pharmacokinetics, it's stable to MAO, so you can use it orally, but it's definitely more reliable as an IV drug or as an inhaled aerosol. And isoproterenol, again, has some very similar adverse effects to epinephrine and norepinephrine. Not going to go through those again. Now, I mentioned way back 40 minutes ago that we would talk about dopamine and dopamine receptors. Well, we're going to kind of get a little bit off track here, and we're going to talk about dopamine, and I'm going to mention the dopamine receptors here. Dopamine can activate alpha and beta receptors. At low doses, it stimulates the beta-1 receptors, and at very high doses, it stimulates alpha-1 receptors, causing vasoconstriction. So this is an important delineation to make when we talk about the clinical uses of dopamine. I'm going to come back to that in a second. Now, I'm going to mention the dopamine receptors here. D1 and D2 dopaminergic receptors occur in the peripheral, mesenteric, and renal vascular beds where they produce vasodilation. So you administer dopamine, and in the mesentery and in the vascular beds of the kidneys, you're going to produce vasodilation. This is super important when we start talking about the actions of dopamine. From a cardiovascular standpoint, at low doses, you're going to stimulate the beta-1, and you're going to get the inotropic and chronotropic effects of the beta-1 stimulation. And at high doses, you're going to get vasoconstriction and increased blood pressure from stimulation of the alpha-1 receptors. Going to go back to those kidneys for a minute. Again, dopamine acts to dilate renal and visceral splanchnic arterioles. These receptors are not affected by alpha or beta blocking agents because they're their own little doodads, they're their own little receptors. This becomes particularly important, again, when we talk about the therapeutic uses of dopamine. dopamine is a drug of choice for shock in the ICU. Why is it the drug of choice? Well, beta-1 receptors, again, are going to stimulate the cardiac output, and alpha-1 receptors are going to increase peripheral vascular resistance. So you're going to bring that blood pressure up in your shock patient. When you bring that blood pressure up with norepinephrine and epinephrine, you're going to box the kidneys. But dopamine has those dopamine receptors in the renal beds, and so we're going to preserve renal blood flow, and we're going to enhance the glomerular filtration rate. You're not going to box the kidneys, and you're going to bring the blood pressure up. A very important and really the cornerstone of treatment when we start talking about the treatment of shock in the ICU. Now, dopamine it's not some panacea. It does have some adverse effects. It will cause a pretty significant sympathetic stimulation, so you've got to monitor your patients very closely in the ICU when you give it to them. And it's very rapidly metabolized, so the effect is very short-lived. You've got to keep them on a continuous IV drip of the stuff. In the clinical setting, dopamine is actually much more complex when used in the ICU shock setting. At low doses, dopamine tends to hit the D1 receptor in the kidneys primarily. And so you really, at low doses, we're talking about 2 micrograms per minute. You're primarily going to see an increase in renal blood flow due to stimulation of the D1 receptors. All right? When we move that dose up a little bit to 5 to 10 micrograms per minute, dopamine acts primarily on the beta-1 receptors in the heart. So now we're going to get some increased heart rate and increased contractility and increased cardiac output. Makes sense. Now, when you turn that dopamine up a little bit more to over 10 micrograms per minute, we're going to be talking about its alpha receptor activity, because dopamine primarily at those high doses is going to hit those alpha receptors, causing, dun dun dun, vasoconstriction and increased blood pressure. So, just to make it a little bit more complex for you, at low doses, dopamine receptors, we save the renal blood flow. Medium doses, we hit the beta-1 receptors, we increase cardiac output. And at high doses, we hit the alpha-1 receptors, cause increased blood pressure. So it's almost like you're using 3 different drugs when you're really just using one. And that's why dopamine maintains its status as one of the drugs of choice in the ICU setting. When we talk about dopamine, we invariably start talking about dobutamine because everybody gets them confused. And the primary reason that everybody gets them confused is not because they're similar or not because they belong to the same class, but actually it's just the name. Dopamine, dobutamine, dopamine, dobutamine. You got to practice it. You got to think it. You got to make sure that you recognize the difference. The difference is quite important, actually. Dobutamine is a synthetic, direct-acting catecholamine, and it's primarily a beta-1 agonist. So remember, beta-1 increases the heart rate, increases that myocardial contractility, and increases cardiac output. So guess where dobutamine is therapeutically useful? It's used to increase the cardiac output, specifically in congestive heart failure, as well as having a use when we start talking about inotropic support for patients who are undergoing cardiac surgery. You really want to get that beta-1 in there, and you want to get it stimulated when you're talking about congestive heart failure. You also want to get in there and get it stimulated when we're talking about supporting a patient who's going through, say, a CABG or some sort of valve replacement surgery where you've got to keep good, nice, tight control of how fast and how hard that heart is pumping. Now, dobutamine has some important adverse effects that bear mentioning. You've got to be really careful in the clinical setting if you use dobutamine and patients have atrial fibrillation, because you also get an increase in the atrioventricular conduction, and you can cause some pretty significant tachycardia that way. Now, prolonged exposure to dobutamine also leads to tolerance of the drug, so you can't use it for too long in the clinical setting. The next drug I want to talk about is oxymetazoline, which is a direct-acting synthetic adrenergic agonist which stimulates both the alpha-1 and the alpha-2 receptors. It's primarily used locally in the eye or in the nose as a vasoconstrictor because it hits those alpha-1 receptors. It becomes useful in the clinical situation when we talk about short-term nasal spray decongestants and eye drops for the rat. Hang on, wait a second. Did we just go from talking about ICU drugs to talking about nasal sprays and decongestants? In fact, it's kind of crazy, but we did. These drugs span the entire spectrum of clinical use, and they're not only very commonly used in the ICU, but they're super common in the drugstore over the counter. They do get absorbed into the systemic circulation regardless, so even oxymetazoline, when you stick it in the eye or use it in the nose, can produce nervousness, headaches, and insomnia. And you also do see some rebound congestion observed with long-term use of oxymetazoline. Another very common drug that we're going to see in the pharmacies and over the counter is phenylephrine. Phenylephrine is a direct-acting synthetic adrenergic drug that binds primarily to alpha-1 over alpha-2 receptors. It's a vasoconstrictor that raises both systolic and diastolic blood pressure. It's primarily used topically on the nasal mucosa as a decongestant. It's also found in ophthalmic solutions. And again, when we talk about drugs that are available over the counter, it's replaced another drug we're going to talk about later called pseudoephedrine in many over-the-counter cold, cough, flu, and allergy preparations. In the not so over-the-counter setting, it's a drug that's used to raise blood pressure, and it's also a drug that's used to terminate episodes of supraventricular tachycardia. In larger doses, though, it can cause hypertensive headaches, it can cause cardiac irregularities. It's just something to be aware of in the clinical setting, but it's definitely a drug that you have to be aware of as your patients are going to be using it over the counter. The next drug I want to talk about is a direct-acting adrenergic agonist, methoxamine. Methoxamine, again, is a direct-acting synthetic adrenergic agonist that binds primarily to alpha-1 receptors more than it does to alpha-2 receptors. The alpha-1 receptors, and I know I've said this a million times, are going to increase blood pressure through their vasoconstrictive properties and thereby increase peripheral vascular resistance. Because methoxamine also affects the vagus nerve, it's often used in the clinical setting to relieve paroxysmal supraventricular tachycardia. It's also a drug that's often used to overcome hypotension during surgery involving halothane anesthetics. Another drug that we've discussed earlier, and bears mentioning at this point, is the direct-acting adrenergic agonist clonidine. Clonidine primarily has its effects on alpha-2 receptors, and so it's used a lot in essential hypertension to decrease blood pressure. Most of this action occurs in the central nervous system. Clonidine can be used to decrease symptoms that accompany withdrawal from opiates and from benzodiazepines, but it acts centrally to produce inhibition of the sympathetic vasomotor centers. It also decreases sympathetic outflow to the periphery primarily by acting on the alpha-2 receptor. It's a super important drug when we talk about the treatment of essential hypertension. The next direct-acting adrenergic agonist I want to mention is metoprolol. And metoprolol is chemically similar to isoprolol, but it's not a catecholamine, and it's resistant to methylation by COMT. It can be administered orally, and it can also be administered by inhalation. Metoprolol acts primarily, but non-selectively, at beta-2 receptors. So it really doesn't produce much of an effect on the heart, but it produces a nice dilation of bronchioles and improves airway function. So it's primarily useful in the clinical setting as a bronchodilator in the treatment of asthma and in the clinical setting when we want to reverse bronchospasm. Not used as often, though, as the next two drugs I want to mention, albuterol and terbutaline. I stick these together because they are short-acting beta-2 agonists that are used primarily as bronchodilators. They really don't have as much of the cardiac stimulation as the other non-selective beta adrenergic agonists like metoprolol. And for me, albuterol is one of the top 5 drugs that I prescribe in internal medicine. The albuterol metered dose inhaler. You're going to hear about it, you're going to know it, you're going to love it, you're going to live it. It is probably the most important drug in the clinic setting that I've mentioned today. I've mentioned a lot of drugs that are much more important in the ICU setting and in the emergent setting. But in the clinic setting, albuterol, one of the single most important drugs that we use. Again, a direct-acting adrenergic agonist, short-acting beta-2 agonist, used primarily as a bronchodilator. Now, there are other direct-acting adrenergic agonists that will work specifically on beta-2 receptors. Salmeterol and formoterol are long-acting beta-2 agonists that are used for bronchodilation in COPD and in moderate to severe asthma. They're usually found as an inhaled powder, which causes bronchodilation for about 12 hours. So why aren't these drugs used over albuterol? You know, albuterol is short-acting, salmeterol is long-acting. It would make sense that in the clinical setting, I'd prefer using something like this for my asthma patients. But it's not indicated in the acute treatment of asthma because the dilation effect doesn't work right away. And this is an excellent pimping question. So be ready for this on the wards. Albuterol, short-acting, quick-acting, used in the acute treatment of asthma. Salmeterol, long-acting beta-2 agonist, doesn't work right away, not really useful in the acute treatment of asthma. But it is recommended in the long-term treatment of asthma. It's not recommended as monotherapy. Usually in the clinical setting, you're going to find it combined with inhaled corticosteroids, and you're going to see a corticosteroid and salmeterol together, and it's going to be something that your patients are going to take to help maintain bronchodilation for 12 hours. You're going to see it in those moderate and severe asthmatic patients again, and it's extremely clinically useful in this setting.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
Welcome back to Who Wants to Be a Gunner? Michael here has astonishingly answered his first question correctly, putting $100 cash on the board. That was a pretty intense one, huh, Michael?
No doubt.
So you're in your 3rd year, correct?
Yeah.
Does your school have some sort of quota program for special needs students?
No. Is that my next question?
Okay then, moving on. Your next question for $200. Which of the following medical conditions can be treated with an epinephrine injection? A. Bipolar disorder. B. High blood pressure. C. Anaphylactic shock. Or D. Erectile dysfunction.
You know, I'm gonna go with erectile dysfunction.
Erection is mediated by the parasympathetic system, right?
Right?
So why would you treat ED with an adrenergic agonist?
Oh, right. Anaphylactic shock then.
Would epinephrine counteract the systemic vasodilation and hypotension associated with anaphylactic shock?
Yes?
Speak up!
Yes!
So is that your final answer then?
Yes, final answer, Regis.
Anaphylactic shock is the correct answer! Mercifully, we are out of time. Join us next time for Who Wants to Be a Gunner?
All right, we're back for our quick review number 2. Let's get started. What are the cardiovascular effects of epinephrine? So we use epinephrine in a lot of different situations, but what does it do? Well, it strengthens the contractility of the myocardium and increases its rate of contraction. You get increased cardiac output. It constricts arterioles in the skin, mucous membranes, and viscera, dilates vessels going to the liver and skeletal muscle, and increases systolic blood pressure and slightly decreases diastolic pressure. Next question. What are some therapeutic uses of epinephrine? Well, acute asthma. So if someone's in dire need of opening up their airway, epinephrine can be used. Anaphylactic shock for certain. Obviously, that's a life-threatening situation. You want to use epinephrine. Open angle glaucoma. Cardiac arrest is a big one. So if you go to your advanced cardiac life support class, you're going to hear about epinephrine. And then as a local anesthetic. Next. Which receptors are stimulated by the following sympathomimetics? So this is a tough question. It would be great if you can memorize all these, but at least if you can get the most important receptor that these medicines affect, that's probably good enough. Clonidine, alpha-2. Dopamine, mostly D1 and D2, but has some alpha and beta. Phenylephrine, alpha-1 greater than alpha-2. Albuterol, beta-2 greater than beta-1. Norepinephrine, alpha-1, alpha-2, and beta-1. Isoproterenol, just beta receptors in general. Epinephrine will do just about all of them, alpha-1, alpha-2, beta-1, and beta-2. Dobutamine will do beta-1 greater than beta-2. And then terbutaline is beta-2 greater than beta-1. Next, which sympathomimetic matches the following statement? And they give us the choices of what we can use on this, so let's go through these. First is given as a nebulizer for asthma. So this is an easy one. This is albuterol. Levalbuterol is another one. The levalbuterol you're only going to give if you had a patient with heart disease, because what does levalbuterol have that's a benefit compared to albuterol? Generally doesn't increase the heart rate quite as much, though it does some. Next, drug of choice for anaphylaxis. We just talked about this, epinephrine. Most common first-line agents for patients with cardiogenic shock. Well, probably the first one you want to put on here is dopamine. Dopamine is used most often for shock, but an alternative would be dobutamine. So dobutamine is often used for cardiogenic shock as well. Next, most common first-line agent for patients in septic shock. So a little bit different than a cardiogenic shock situation. Often we're going to use norepinephrine in septic shock, but know that the best thing you can do is give someone with septic shock fluids. You always want to make sure people have IV fluids, because most of the time people who are in septic shock, they have a functioning heart. And if their pressure is just going down, if you give them fluids, they generally do better too. Next, give sub-Q for asthma. That's going to be terbutaline. Used by ENT to vasoconstrict nasal vessels. That's going to be phenylephrine or cocaine. Next question. What drug would be most appropriate to give a patient in shock because it maintains renal blood flow? So which medication maintains renal blood flow? Dopamine. So dopamine is the answer to this one. Next question. What are some therapeutic uses for dobutamine? Well, we talked about cardiogenic shock, but it can be used on a more chronic basis to help increase cardiac output in congestive heart failure. And then it can also be used in cardiac surgery, so inotropic support after cardiac surgery. So if you need to really maintain good cardiac support, then you can use dobutamine as well. Next question. A patient comes into your office with severe nasal congestion. He reports using Afrin or oxymetazoline every day for the past week with great relief, but now it doesn't seem to be working. What is the patient experiencing due to long-term use of this drug? So this drug is commonly the culprit for rebound congestion. There were times many years ago when things like Afrin were used a little more often, and people had to carry around a bottle of the medication in their pocket because multiple times a day they'd have to use their medication to help prevent that rebound congestion. So how long should we tell patients to use these medications? I usually tell them no longer than about 2 days. You know, if you're having a horrible time, if you can't breathe at night, if it's keeping you from sleeping, yeah, you can use a little bit of that medication in order to just relieve you of those severe symptoms. But really, after about 2 days, stop doing that because you're going to get that rebound congestion. Next question. Which inhaled adrenergic agonist has the longest duration of bronchodilation and is therefore useful for long-term treatment of moderate to severe asthma? Well, salmeterol is the answer. Now, most of the time you're not going to give a patient just salmeterol by itself. Occasionally you will, but it's often packaged together with inhaled corticosteroids. So for patients who flip into the mild persistent or moderate persistent asthma category, you're going to want to add on an inhaled steroid anyway. So we generally combine that with the salmeterol and you get better symptom relief. Next question. What test can be used to identify a patient who has a pheochromocytoma? So we didn't talk about this problem in the lecture, but what is pheochromocytoma? Well, it's basically an overproduction of your catecholamines. So you have a tumor that's secreting all these catecholamines, and you're going to get a lot of the symptoms associated with that. So you get a lot of uncontrolled hypertension, sweating, you lose a lot of weight, you have a lot of tachycardia. So how do we find this stuff? Well, you have to look at urine catecholamines, but not just catecholamines, but the catecholamine metabolites. So you're going to look at metanephrines or norepinephrines. Because since the epinephrine and the norepinephrine, these catecholamines released from the adrenal tumor are rapidly metabolized. So you're not going to see plain Jane norepinephrine, you're not going to see plain Jane epinephrine in the urine, you're going to see these metabolites. Next question. What can be given to avoid the reflex bradycardia when treating shock with norepinephrine? Well, you can go with atropine. Atropine blocks those vagal effects from the baroreceptor stimulation, and then you can prevent that reflex bradycardia. All right, that's going to conclude our quick review number 2. Let's get back to the lecture.
Let's switch gears and talk about the indirect acting adrenergic agonists now. Indirect acting adrenergic agonists are going to cause norepinephrine release from the presynaptic terminal, or they're going to inhibit the reuptake of norepinephrine. So basically, what they're going to do is they're going to potentiate the effects of norepinephrine. And there's a couple of drugs that bear mentioning when we talk about the indirect acting adrenergic agonists, specifically amphetamine, tyramine, and cocaine. Indirect acting adrenergic agonists are pretty well characterized by amphetamine. Now, amphetamine has a marked central stimulatory activity. Peripherally, amphetamine can increase blood pressure markedly because of the alpha-1 effect of vasoconstriction, as well as the beta-2 effects on the heart. How could this be useful in the clinical setting? Well, it becomes useful in a couple of interesting ways. In the internal medicine setting and in the general medicine setting, we often find amphetamine used as a weight loss drug because it has some central effects that are important, and it also has the peripheral lipolysis effect, which can be somewhat important. CNS effects have led to a clinical use for amphetamine in the treatment of appetite control, also in the treatment of narcolepsy, and also in the treatment of attention deficit hyperactivity disorder in children. The second indirect acting adrenergic agonist I want to mention is tyramine. And tyramine isn't really clinically useful. It's common in fermented foods like ripe cheese and Chianti wine. Like amphetamine, tyramine can enter the nerve terminal and basically potentiate the effect of norepinephrine. However, tyramine is oxidized by MAO in the GI tract. So if a patient is taking MAO inhibitors, tyramine found in cheese and in Chianti wine becomes particularly important because this agent can cause serious hypertension. The final indirect acting adrenergic agonist is probably one of the most common drugs that you're going to see when you get into the emergency room and onto the hospital wards. Cocaine is a stimulant of the central nervous system, and it's a drug of abuse that is going to get discussed a lot in later lectures. But it bears mentioning here, again, because it's an indirect acting adrenergic agonist. It's going to increase blood pressure peripherally by its alpha agonist and beta stimulatory effects. It's also, believe it or not, found clinically. As a local anesthetic, cocaine blocks sodium potassium ATPase on the cell membrane of the adrenergic neuron and thereby blocks the norepinephrine reuptake. Now, norepinephrine tends to accumulate in the synaptic cleft and enhances sympathetic activity and potentiates the effect of epinephrine and norepinephrine. Now, if you remember back from 20 minutes ago when we talked about epinephrine and its use as a local anesthetic, you potentiate the effects of that epinephrine and you're going to potentiate the effect of things like lidocaine when used as a local anesthetic. It's also going to potentiate the effects of that cocaine. Let's go over the third group that we mentioned, mixed action agonists. Mixed action agonists are called mixed action agonists because they have an indirect action as well as a direct action. Again, what they're going to do is these drugs are going to induce the release of norepinephrine from the presynaptic terminal, and they're going to activate adrenergic receptors on the postsynaptic membrane. There are two drugs that we're going to talk about in this category, ephedrine and pseudoephedrine. A little bit about the pharmacokinetics of these drugs. They're not catecholamines, so they're a poor substrate for COMT and for MAO, and thus also have a longer duration of action. Again, because they're poor substrates for COMT and MAO, you guessed it, they have a very excellent oral absorption. And because they're non-catecholamines, they have very good CNS penetration. In terms of the metabolism of these drugs, ephedrine is excreted pretty much unchanged by the kidneys, while pseudoephedrine is partially metabolized in the liver and then excreted into the kidneys, or through the kidneys. Ephedrine is going to increase the systolic and the diastolic blood pressure by vasoconstriction, alpha 1, as well as cardiac stimulation, beta 1. Ephedrine and pseudoephedrine are going to also cause some degree of bronchodilation, beta 2, but it's really less potent than epinephrine or isoproterenol. Because of the CNS penetration, ephedrine and pseudoephedrine are going to stimulate the CNS, and they're going to increase alertness, decrease fatigue, and prevent sleep. Ephedrine and pseudoephedrine have been used to treat asthma, but they're primarily found in nasal decongestions. Pseudoephedrine specifically is primarily used to treat nasal and sinus congestion or congestion of the eustachian tubes. When given, it is going to cause a pretty strong vasoconstriction via those alpha 1 receptors, and that vasoconstriction is going to reduce nasal and sinus congestion. So it sounds like pseudoephedrine can be found all over the place. And it's actually very useful in the over-the-counter setting. But there is a little bit of controversy surrounding this. Now, ephedrine-containing herbal supplements were banned by the FDA in 2004 because of life-threatening cardiovascular reactions. Pseudoephedrine has been illegally converted to methamphetamine. So these products have now become fairly restricted. And the current law is that you've got to keep them behind the sales counter in pharmacies. They're still available, drugs that contain pseudoephedrine, but again, a little bit restricted, and these commonly used drugs are now becoming less commonly used because of these controversies.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together, we'll go through the quick review in the study guide. All right, we're back and it's time for quick review number 3. Let's get started. How do amphetamines increase blood pressure? Well, they do it by a couple of different ways. First, they cause vasoconstriction because of the alpha receptors, and which receptor more specifically? Alpha 1. And they have beta stimulatory effects on the heart. And which one is more specific to the heart? Beta 1. Next, if a patient is taking MAO inhibitors and has a passion for drinking wine, what may he experience with this combination and why? Well, the answer is hypertensive crisis, and this is why. So if you have an MAO inhibitor, that means you're going to have a higher concentration of catecholamines in that neuron. Now, tyramine, for some reason, will also cause this sort of dumping syndrome where all those stored catecholamines get released from that neuron. So anything with aged ingredients, so not just Chianti wine, it's actually pretty much all wines, though Chianti might be a little bit worse, but wines, aged cheeses, beer, things that are aged tend to have a lot of tyramine in them, and you want to avoid those if you're taking an MAO inhibitor. Now, luckily, very few people take MAO inhibitors anymore for depression, so you don't run into this too often. Next question. What is the mechanism of action of cocaine? Well, first, it blocks the sodium-potassium activation ATPase. It will cause accumulation of norepinephrine in the synaptic space, and then also resulting in potentiation of the actions of epinephrine and norepinephrine and increase the duration of action. So you've got more epinephrine hanging out, and then that norepinephrine in and of itself will be more powerful. Next, what is the mechanism of action for mixed action adrenergic agonists? So you get this induce the release of norepinephrine from presynaptic terminals. And then you also activate adrenergic receptors on the postsynaptic membranes. Next question. What are the effects of ephedrine and pseudoephedrine? Well, it increases systolic and diastolic blood pressure. You get some cardiac stimulation, and you get bronchodilation. But you also get difficulty sleeping as well, so it'll sort of stimulate you. Next question. Where are ephedrine and pseudoephedrine primarily found? So what type of drugs are we going to find these in? Nasal decongestants. So most of the time these are over the counter, so they're easily accessible. Next question. What abused drug is easily synthesized from pseudoephedrine? So this is not as big of a problem. Well, it's actually still a huge problem. But now that they put pseudoephedrine behind the pharmacist's counter, it's a little bit harder to get mass quantities of pseudoephedrine over the counter. Methamphetamine is what you can make, and it's still a major problem in the world, but it's a little harder to buy 14 boxes of pseudoephedrine at the pharmacy. You have to get them by other means nowadays. All right, so that's going to conclude our third quick review. It's time for our end of session quiz. So I want you to stop the video. I want you to answer all the questions in the end of session quiz, and then restart the video, and we'll go over the answers together. All right, it's time for the end of session quiz. Let's go over these answers. First one, how do indirect acting adrenergic agonists differ from direct acting agonists? So It's in the name itself, indirect. So the indirect acting adrenergic agonists will either release norepinephrine while it's being stored, or it will inhibit the reuptake of norepinephrine or other catecholamines. So they potentiate the effects of norepinephrine, but they don't directly affect the postsynaptic receptor themselves. So they're just allowing those catecholamines to work better or have them get released at higher concentrations. Next question. What is the primary mechanism by which norepinephrine is removed from the synaptic space? What are some drugs that can impact this method of removal? So we talked about this once before in a question. First, you can diffuse out of the synaptic space into the circulation, and I'm talking about the norepinephrine. It can be metabolized or broken down by COMT. And then the sodium-potassium ATPase pump can actually pump norepinephrine back into that presynaptic neuron. And the type of medications that can affect this, TCAs or tricyclic antidepressants and cocaine can help make norepinephrine become more concentrated in that synaptic space and last longer. Next question. Which receptor predominates in the heart and also in the skeletal tissue? So we've talked about this before. You really need to remember this. Beta-1 receptors are in the heart. You're not going to find a lot of other receptors in the heart, but there's a lot of beta-1. What are you going to find in skeletal tissue? Beta-2. So beta-1 heart, beta-2 skeletal tissue. Next. Which adrenal receptors are involved in the following major effects? So we keep pounding this into you. What do these receptors do? It'll really pay off for you if you learn these things well now, because when you start talking about drugs, it'll be clear in your mind. So major effect, inhibition of norepinephrine, acetylcholine, and renin. So what's that? Alpha-2. Next, vasodilation, bronchodilation, that's the key, increase gluconeogenesis, increase glucose release, and relax the uterus. That's, of course, your beta-2. Next, tachycardia, increase myocardial contractility, increase lipolysis, increase renin release, beta-1. And then finally, vasoconstriction, increase peripheral resistance, that's the key, increase blood pressure, mydriasis, closure of internal bladder sphincter, alpha-1. Next, match the following clinical descriptions with the most appropriate therapeutic agent. So first we have a 57-year-old hypertensive man comes to the outpatient clinic with a blood pressure of 185 over 115. So he's got some worrisome malignant hypertension. We didn't tell you anything about whether or not he had in-organ damage or something else going on. But what are you going to use in this situation, or what you can use in this situation, is clonidine. Next part of this, a 72-year-old man with congestive heart failure. There's lots of medicines you can use, but in regards to this lecture, you can use dobutamine is the answer. Next, an 8-year-old boy comes in status post bee sting and anaphylaxis. So that's a scary situation. What are you going to use? Epinephrine. Next, a 62-year-old woman with COPD needs a long-acting inhaler. Remember, this is the beta-2 agonist, and the long one is salmeterol, often combined with your corticosteroids. Next question. Which adrenergic agonist has greatest effect at D1 and D2 receptors and is the drug of choice for shock because it maintains renal blood flow? We've asked this a couple times. We're pounding it into you. Dopamine. Name the common side effect for each of the following. So epinephrine, you're going to get CNS effects, you're going to get hemorrhage, you're going to get cardiac arrhythmias, pulmonary edema. Oxymetazoline, nervousness, headache, insomnia, that's a big one. Rebound nasal congestion, that's even a bigger one. Phenylephrine, hypertensive headaches, and cardiac irregularities. Next question. What are some clinical uses for amphetamine? So it's not just a recreational drug. We use this quite often for other things. First one is weight loss and appetite control. This gets abused, in my opinion, to some extent. A lot of people are using this for weight control and appetite control. Not a lot of good long-term data that keeps weight off for long periods of time. Narcolepsy can be very helpful to help keep people from falling asleep all the time. And then probably where it's used most often is attention deficit hyperactivity disorder. Most often in children, but still used in adults as well, and you always have to watch out. That's a controlled substance, and you have to pay attention to how things are going with that medicine. Why does norepinephrine cause bradycardia? So it seems a little counterintuitive. Norepinephrine, I thought this was stimulating, increasing blood pressure and all that type of stuff. Why would it make bradycardia? Well, it's because of this baroreceptor reflex. So this causes a reflex bradycardia. Next question. Why does clonidine cause a decrease in blood pressure? So this is another one of those you kind of have to flip your brain around a little bit because most of these things we automatically think adrenergic, well, I'm increasing heart rate, I'm increasing blood pressure, but then in the same category we're talking about a blood pressure medicine that decreases blood pressure. So clonidine is an alpha-2 agonist. So what did alpha-2 do? Where does it live? Well, alpha-2 receptors are found on the presynaptic neuron. So they're not on the effector organ, they're on the neuron itself. So if you imagine norepinephrine being shot out of that presynaptic neuron, some of that norepinephrine does a U-turn and does a negative feedback back on to that alpha-2 receptor. And what does that alpha-2 receptor do when it gets that norepinephrine? Well, it tells the neuron, stop sending out norepinephrine, we're done. So it's a negative feedback, it decreases the overall release of those catecholamines. So it's a negative feedback, and that's why it causes a decrease in blood pressure, because if you have less norepinephrine floating around, then you're going to decrease that blood pressure, and that's why it's so effective. All right, so that's going to be the end of